Now to dive more onto data on pancreatic cancer, here is Dr. Tanios Bekaii-Saab, a medical oncologist at Mayo Clinic. Thank you so much for being here, Dr. Bekaii-Saab.
Thank you. Exciting times in pancreas cancer.
Absolutely.
Quite amazing data. Some numbers that I don't think we've seen before in pancreas cancer. First we have a study that produced 24, which looked at an adjuvant approach. We've been waiting for quite a long time for the results of the study, excited about trying to move the needle forward with pancreas cancer. The study was simple. Compare FOLFIRINOX, modified FOLFIRINOX, to gemcitabine. Gemcitabine was the standard of the time before gemcitabine, capecitabine. And so the study actually was a large study. I have to tell you, I'm disappointed it wasn't a plenary session. It should have been a plenary session. So patients were randomized to modified FOLFIRINOX and gemcitabine, close to 500 patients. And the primary endpoint of the study was disease-free survival. So the disease-free survival were in the gemcitabine arm was 12-ish months, which is what you would expect from gemcitabine. With FOLFIRINOX, it was 26.1 months. So pretty impressive. And then when we look at the survival with gemcitabine was 34 months, and with modified FOLFIRINOX, 54 plus months.
Wow.
54 plus months. Now this is a disease. Just a short few years ago, when we were looking at the adjuvant data, what we would hope for is 22, 23 months on survival. Now this is doubling the survival. Now multiple factors for that. It's not just what the drug or what the regimen is doing, because with gemcitabine alone, we wouldn't expect a 34-month survival. A lot of these patients do progress, and we have much more active regimens down the line. But the disease-free survival tells us also that it's a regimen effect. FOLFIRINOX indeed moves the needle and moves it quite nicely. And I think it should be considered now a standard for our patients with pancreas cancer who have resection or resected pancreas cancer and who are eligible. Challenges, well, there are a few challenges. One, the standard arm was gemcitabine. Today, our standard arm gemcitabine, capecitabine. Difficult to do extrapolations. Second limitations is we're still waiting on the data with gemcitabine, nab-paclitaxel. Hopefully will be presented by the end of the year. The APEX study, randomizing patients to gem, nab-paclitaxel versus gemcitabine. And third limiting factor is, of course, who are those patients that we're really going to be able to get through FOLFIRINOX. There are other limiting factors from how we interpret the study. CA99 had to be no higher than 180. Some patients following surgery may be higher than that. So what do we do with them? Do we give them the FOLFIRINOX or not? We don't have that data. In our practice, we tend to move the everything to preoperative anyways. So what we call a total neoadjuvant approach. We take with FOLFIRINOX typically, or gemcitabine, nab-paclitaxel for some patients, and occasionally radiation for select patients, followed by surgery. Why do we do that? I think the strength of the adjuvant study tells us that you need surgery and chemotherapy, maybe radiation. The problem is that a lot of patients will not be able to make it to get FOLFIRINOX. However, if you move this to the preoperative setting, it's more likely that we're going to expose more patients to treatment that will likely improve their survival. We also will probably select better who needs to go to surgery. So a lot of exciting things about this data that consolidates, one, that we need to be more aggressive with our patients, but also we have to be mindful of the fact that limited exposure to dose-intensified treatments before surgery will likely make better. And that leads to the segue to the second abstract that was released today. And this was the pre-op PANC one. And this study essentially was designed to include both patients with borderline resectable as well as clearly resectable patients. These patients received either chemotherapy and radiation or no therapy before surgery, and then after randomization went to surgery or pre-op chemo-rad, surgery, then everyone received adjuvant chemotherapy. From this study, although it still needs to mature a little bit longer, it seems that the preoperative approach with chemotherapy and radiation improves outcome. And so that again makes a strong case for considering neoadjuvant therapy. Now, one could argue that this study has its limitations. Chemorad alone is not a standard. Borderline resectable patients should never go to surgery first. They should get chemotherapy and chemorad. And so there are limitations on how to interpret them. The way I look at this in the big scheme of things is that it tells me that the neoadjuvant approach is a very viable approach, and in my institution, a preferable approach. So these are two very exciting studies that keep on considering. We're looking for more data, hopefully, around ESMO and ESMO GI. And another area of interest is, again, along these lines of dose intensification and what do we do with our patients with metastatic pancreas cancer now. FOLFIRINOX is a tough regimen. It's really not easy to give. Gemcitabine nab-paclitaxel has its issues. Weekly gemcitabine nab-paclitaxel tends to be tough as well. So we in our institution move primarily to every other week. But nonetheless, FOLFIRINOX remains a very active regimen, but it's been limited to those patients with high performance status or those patients who are younger. So one of the studies, Prodige 35, thank you. A lot of prodiges today, prodige galore.
Right.
This study essentially looked at 3 questions. We'll focus on 2 because I think clinically those 2 are relevant in a randomized fashion. 1, we give FOLFIRINOX for 6 months in the adjuvant setting. In the metastatic setting. 2, we give FOLFIRINOX for a limited amount of time, 3 months, and then followed by maintenance infusion of 5-FU, and then reintroduce oxaliplatin at progression. Interestingly, this study showed that the benefit was very similar in both arms. What that tells us essentially is that, yes, we don't have to expose our patients to FOLFIRINOX until the toxicities hit or progression. We can limit to 3 months and then shift to 5-FU. One thing about this study that was interesting is that patients that progressed on 5-FU and got reintroduction of oxaliplatin, so that arm, there was a much higher risk of neuropathy or neurotoxicity, probably because they were exposed to more oxaliplatin than they should. So I think that is one limiting factor here. So we take a step back and we think, so what would be today the patient who comes to your clinic? What would you do with the patient who comes to your clinic and you plan to give that patient FOLFIRINOX? I think it's safe to say that you do FOLFIRINOX for 3 months, 4 months maybe, then followed by infusion of 5-FU, arguably also capecitabine if you want to shift to oral. And then upon progression, I would not reintroduce oxaliplatin unless there's evidence of zero neuropathy, and I would shift to the next regimen. This question of maintenance has become very relevant in our world. We expect the results of POLO 2 sometimes in the near future, POLO. And the POLO study essentially looked at olaparib, a PARP inhibitor in patients with germline BRCA2, BRCA1, BRCA2 mutations that received FOLFIRINOX for a limit, or gemcitabine cisplatin or other platinums, FOLFOX, for a limited amount of time, and then they went on maintenance strategies. So these maintenance strategies are going to prove to be very important to understand in pancreas cancer. Limiting intensive treatment to 3 months and 4 months is feasible, is merciful, and is effective, and will allow us to essentially create maintenance strategies so we can go for that marathon rather than sprint.
Wonderful. What about with the gastrointestinal cancer abstracts being presented here? What does that really tell about the future of GI cancers?
I think overall we're seeing a lot of exciting data. We're seeing a lot of positive data. We are on the right track and asking the right questions. More positive data in this setting than negative, which is not always the case for our cancers, for gastrointestinal cancers. The one thing that's lacking, but is being worked at very aggressively, is starting to really break down our GI cancers into multiple buckets, molecularly driven, immune-driven buckets and start really piecemealing these cancers into these buckets and hit them. The future is being forged yesterday, but we won't have any results yet. So we know that now we're on the right track. We know that we can limit the intensity of treatment. We know that more is not necessarily better, but less can be better in some patients. And so that helps us establish, future platforms for our immune therapies and for our target therapies. So overall, I'm very excited about this symposium.
Great. Well, thank you very much for joining us today, Dr. Bekaii-Saab. We really appreciate it.
It's always a pleasure.
Thanks.
Thank you. All right.